This study is entitled Reoperation Rates of Stress Incontinence Surgery in Rural versus Urban Hospitals. The authors of the study were Saniya Ablatt, Amelia Kirchhoff-Rowald, Suman Sahil, Dr. An-Lin Cheng, Wang, Dr. Jonathan Shepard, and Dr. Gary Sutkin. To introduce the study, the objective was to determine the impact of rural versus urban hospital location on the risk of having a second surgery for stress urinary incontinence. Since approximately 180,000 surgeries are performed every year for urinary incontinence, operative complications, reoperation, and readmission are not uncommon. Although it is known that repeat surgery is inversely related to surgeon experience, it is unknown what role hospital characteristics play in the rate of reoperation after mid-urethral sling. Our goal is to examine whether rural versus urban hospital status affects the risk of having a second operation, such as a revision or repeat SUI procedure after mid-urethral sling. Regarding the methods of our study, we used de-identified nationwide patient data from Cerner Health Facts database to compare two cohorts of women who underwent surgery for SUI. The first cohort underwent a second surgery of either a repeat procedure for recurrence of SUI or a revision of their index surgery. The second cohort did not undergo a second surgery. We identified all patients who underwent procedures for SUI between January 1, 2010 and November 30, 2018. We used CPT codes to identify these patients. For those with a reoperation, we used any patient who underwent an initial SUI procedure and received a repeat SUI operation more than 30 days later, or those patients that underwent revision, which could have occurred at any point after their index surgery. The second cohort were those that underwent an initial SUI surgery but no reoperation. Using the student's t-test and chi-square tests, we compared risk factors available in the Health Facts database and their effect on reoperation. Rural versus urban hospital status was defined using hospital zip codes within the Health Facts database. We then performed multivariable logistic regression to identify risk factors for reoperation, including sociodemographic variables with p less than 0.1 on univariable regression. Rural versus urban status was included in the final regression despite having univariable analysis with p greater than 0.1, as it was the variable of interest. After identifying independent risk factors, we included unadjusted and adjusted odds ratios and 95% confidence intervals. Baseline demographics and potential confounders, as well as multivariate regression, are presented in the tables of this poster. For our results, we identified 25,085 patients who underwent SUI procedures within our timeframe. The 5 variables with p less than 0.1 on univariable analysis included age, bed size, obesity, anticholinergic use, and concomitant prolapse surgery. Rural versus urban hospital status did not differ significantly between the two cohorts. All 6 variables were included in our multivariable analysis. This showed that rural versus urban hospital status still did not significantly impact the risk of reoperation after adjusting for confounders. Obesity increased the risk of operation, and concomitant prolapse surgery decreased the risk of repeat operation. When compared to the smallest hospitals with 0 to 5 beds as a reference group, hospitals with bed size 200 to 299 had decreased risk of a second operation, but no other bed sizes had a significant impact. Age and anticholinergic use were no longer significant on multivariable analysis after adjusting for confounders. For our conclusion, we were unable to show any significant impact of rural versus urban hospital location on the risk of having a reoperation after SUI surgery. However, we found that obesity increases this risk, while concomitant prolapse surgery and hospital bed size of 200 to 299 decrease this risk. Strengths of our study include the use of the Health Facts database, which is a validated nationwide database that provides data input from thousands of patients. This gave our study a large sample size with strong external validity and greater power to detect any differences. Limitations of our research include the ability to predict outcomes for patients who had procedures outside the Cerner database. Overall, our findings support that for surgical management of stress urinary incontinence, patients in rural communities can be assured that they are receiving comparable care to urban centers.